a key population at higher risk due to engagement in sex work of many female IDUs. Next slide, please. PLHIV, or persons living with HIV, are often confronted with stigma and discrimination, especially in accessing health services, education, employment, and other social services. Based on the recent assessment of our AIDS Medium-Term Plan 4, only 18 out of the 48 localities identified as highly vulnerable, including the national capital, Metro Manila, were reached with preventive measures, while 10 of them received comprehensive essential prevention measures. The challenge we face now is how we can strengthen the response at the decentralized system where local government units are given the vital role in pursuing long-term sustainability of response on STI and HIV. High HIV vulnerabilities related to unsafe migration and mobility call for concerted responses in responding the entire spectrum of migration from pre-departure to post-arrival phase. Next slide, please. The following or succeeding slides I will be presenting will show or present how the country responds to these health threats. The country's response to HIV and AIDS is based on the Philippine AIDS Prevention and Control Act of 1998, or RA 8504, which was enacted on February 13, 1998, and its implementing rules and regulations promulgated in April 13, 1999. The law promulgates policies and prescribes measures for the prevention and control of AIDS in the country. It institutes a nationwide HIV and AIDS information and education program, establishes a comprehensive HIV and AIDS monitoring system, and strengthens the Philippine National AIDS Council. Next slide, please. The national response is presented in the law in its 8th article. In this slide, we have the 8 articles. Article 1 is on education and information. Article 2 is on safe practices and procedures. 3, testing and screening, as well as counseling. 4, health and support services. 5 is on monitoring. 6, confidentiality issue. 7, discriminatory acts and policy. And last, number 8, is on the Philippine National AIDS Council. Next slide, please. Considerable initiatives had been put in place since our first Filipino HIV positive case was reported in 1984 until the present. In 1992, the country was among the first in the region to set up one national coordinating body that focused on policy making to address HIV and AIDS situation in the country. The Philippine National AIDS Council, or what we call PNAC, was established through Executive Order Number 39, a central advisory body to the President and the Legislative. PNAC is a multi-sectoral council chaired by the Secretary of Health, with members presenting 17 key government agencies, 6 civil society from sectors affected by the epidemic, and 2 from people living with HIV. The day-to-day affairs of the Council is being coordinated by the Secretariat with staff from the Philippine Department of Health. Next slide, please. The national response to AIDS epidemic in the country is embodied in the AIDS Medium-Term Plan 4, or AMTP4. This strategic plan was conceptualized and prepared through a robust and wide consultative process, which was inclusive of civil society, different agencies of the government, multilateral, bilateral agencies, as well as corporates. The AMTP4 is the national blueprint of the national response to AIDS. It assists the country in the formulation of policies and prescribed measures to combat further spread of the virus. It likewise sets the environment to institute a national or a nationwide HIV and AIDS information and education program, establishes a comprehensive HIV and AIDS monitoring system, and strengthens the National AIDS Council. The Philippine National AIDS Council is responsible for overseeing the program implementation of this country plan. To operationalize this strategic plan, a national response to AIDS epidemic of the country is embodied in its operational plan 2007 to 2008. In 2008, the Council conducted a midterm assessment of its AIDS Medium-Term Plan 4, and results of this review informed the operational plan for 2009 to 2010, and subsequently the final assessment to be conducted in the early part of 2011. Next slide, please. AMTP4 will run from 2005 to 2010 with an aim of preventing further spread of HIV infection and reduce the impact of AIDS on individuals, families, and communities. It has 4 objectives as shown in this slide with corresponding strategies. Next slide, please. The succeeding slide, I will be presenting the different initiatives the country has taken on and systems put in place since the first case of HIV was reported. In 1998, National AIDS and STD Prevention and Control Program and AIDS Registry was established. From 1988 to 1993, the first AIDS Medium-Term Plan, or first AMTP, was developed. In 1994, the first organization of people living with HIV was organized in the country. It was also during this period that the country established the AIDS Surveillance Education Project in 10 sites. Next slide, please. In 1995, Bahay Lingap, a halfway home for asymptomatic Filipino living with HIV and AIDS, was inaugurated. In 1998, marked significant events in the country's response to the virus. This is the year during which the AIDS law was enacted. Next slide, please. It was between 1995 to 2000 that important policies were formulated. The HIV and AIDS workplace policy was formulated by the Department of Labor and Employment. The Philippine Information Agency developed the STI and AIDS mass media campaign and a manual for media practitioners. Issuance of memorandum order and development of modules integrating AIDS in the school curricula, including non-formal education, was released by the Department of Education and the Technical Education and Skill Development Authority, respectively. Memorandum circular was also released by the Department of Interior and Local Government, which directs local government executives to implement HIV and AIDS education and community-based services. This subsequently paved the way for the formulation or creation of local AIDS council and an enactment of local AIDS legislation in some cities and municipalities in the country. To date, there are 32 local AIDS councils established. Next slide, please. From 2000 to 2004, we institutionalized the LGU, or the Local Government Unit, and non-government organization partnership in several cities. The local AIDS council were established and local AIDS ordinances, including provision of budgetary allocation for HIV and AIDS activities, were enacted. In 2001 to 2004, the country was a signatory to the UNGAS Declaration of Commitment on HIV and AIDS and adopted the UNAIDS 3.1s. The 3.1s adopt the Common Action Work Plan, which is the AIDS Medium-Term Plan, a national coordinating body, which is the Philippine National AIDS Council, and the establishment of a country monitoring and evaluation plan. Next slide, please. In 2007 to the present, we piloted the implementation of prevention of mother-to-child transmission guidelines. To strengthen local response, we established the Regional AIDS Assistance Team, or RAAS, which was composed or is composed of 3 national agencies: the Department of Health, the Department of Social Work and Development, the Department of Interior and Local Government, to assist local government units in their local response. In 2008, we also initiated the midterm assessment, which results to the review of our plan. For this year, we are finishing our report to the President of the Philippines. PNAC-UNDP Joint Program on HIV, promoting leadership and mitigating the negative impact of HIV and AIDS in human development, which will run from 2009 to 2011, is being implemented this year. Next slide, please. In the areas of treatment, care, and support, some milestones I want to share with you are the following guidelines, standards, and protocol for reporting, treatment, care, and support. These are the National STI Case Management Guidelines, guidelines on the entry of people with HIV and AIDS to the Philippines, guidelines for AIDS investigation, guidelines on management on HIV infection, home-based and hospital-based care guidelines, and care and support training manual for social workers. Next slide, please. As shown by the HIV data, much is needed to be done still by us as a country. A multi-sectoral response where local response is at the center is highly desired for. Our aspiration is to contain the epidemic and harnessing the gains of the past and applying the knowledge of the present. We look at packaging our intervention that will reach the widest portion of our target groups and empower them to make or to take on behavior change. And lastly, our concern is to sustain the country's procurement of ARV and encourage and build a greater and meaningful engagement of people living with HIV. Maraming salamat po. Thank you.
Salamat po. Thank you. Now I would like to invite Dr. Mario Agustin to present Timor-Leste HIV/AIDS situations and response. Dr. Agustin. Dr. Agustin, now it's your turn to present Timor-Leste HIV/AIDS situation and response. Hello? Hello, Timor-Leste? It seems that we have...
Timor-Leste. This will be a short presentation.
Okay, please, Dr.
Okay, it is okay now?
It's okay now. We can hear you loud and clear.
Thanks for welcoming me for the presentation. It will be a very short presentation. What will be the course objective? It will be first to know the prevalence of HIV/AIDS epidemic in Timor-Leste, know the impact of the epidemic, and identify challenges and opportunity in terms of HIV/AIDS programming. First of all, let us start with a brief background of the country. Let us say that Timor-Leste is sharing the island of Timor with Western Timor, and it is called Timor-Leste or Timor-Leste, but the official name is Republic Democratic of Timor-Leste. It has been... I would like to ask if you are seeing the PowerPoint presentation. Jakarta, Do you see the PowerPoint presentation? Jakarta, are you listening?
We have your slide Yeah, we have your slide on the screen, Dr. Agustin.
Yes, we hear you.
Thanks, I can proceed. Okay, thank you. So, like I said, Timor-Leste is the newest nation in the world. It has been independent from in 2002. And it is considered one of the least developed countries in Southeast Asia. Let us say that the demographic data from the 2004 census says that we have approximately 1 million persons living in Timor, with a population growth of more than 3.2%. But the fecundity rate is very high. We have more than 7 babies per woman, and the population is quite young. Like I say, the latest data shows that 61% of the persons living in Timor-Leste are below 25. The literacy rate is about 73%, but it depends. If you go higher, the high university knowledge is very low. But the general literacy rate is approximately 73%. In terms of economic data, we can say that Timor-Leste is considered one of the least developed countries, and they live with less than 0.8 cents a day. So this is data that can show you the difficult situation that Timor-Leste is facing. Now, in terms of HIV-AIDS, what we can say? That we can say that in terms of HIV-AIDS, Timor-Leste is still considered a low prevalence country. It means that the prevalence is 0.17 to 0.23%. It means that it is an estimation. And we can say that actually 94 cases in October 2008 have been identified by the Ministry of Health. But we can say that the latest data, for example, published by the Ministry of Health, shows that there is more than 117 persons infected in Timor-Leste. And 30 of them are receiving ARV drugs. The age group of the person infected with HIV, they are between 15 to 39. And the youngest case identified is a young kid, 13 of age. Now, what about the HIV-AIDS response in terms of Timor-Leste? Like I said before, the prevalence of HIV is very low in Timor-Leste, and still it is not considered a high priority by the government. Because Timor-Leste, as I said, is the newest country in the world, and they have other commitments, other priorities. And the existing program is targeting the most at-risk groups, including MSM, men having sex with men, sex workers, uniformed service members. There is no such program for injecting drug users. And there is no direct program targeting the general population. Most of the programs are being implemented by NGOs and through the Ministry of Health. The challenge, like I said, it is the same as everywhere. We have the low use of condom because of culture and religion, because data shows that people still do not use condom because of culture, because of religion. I have to say that the Catholic Church is very present and is very powerful in Timor-Leste, and people, they hide about on their belief when he has when you tell them to use condom. There is also another challenge, the lack of information in vulnerable groups. Like I said, in 2004, a study from FHI shows that only 29% of sex workers were in fact using condom. And in the last study shows that only in the general population, only 15% of the people know about HIV/AIDS. In the health sector, there is a VCT center, but until now they were not very active. But from this year, they have installed more than 15 VCT centers. So that's why they managed to find out in less than this last quarter 13 new cases of HIV/AIDS person living in Timor-Leste. And the PTMC, that the program for the pregnant mother, to prevention of transmission mother to child, is quite not very well. And in terms of challenge also, we can say that the governance of HIV/AIDS program is still, like I said before, Timor-Leste needs to build its capacity in terms of governance, not only governance in terms of HIV/AIDS program, but also in governance in terms of other issues. And the availability of data usually is very challenging. It is very difficult sometimes to obtain clear data related to HIV/AIDS, not only for HIV/AIDS, but also for other topics, other themes that are related to the country. And the last but not the least, the stigma and discrimination factor. Because although there is a drug available in Timor-Leste, although there is a service available in Timor-Leste, but people, by fear of stigma and discrimination, people do not frequent the health center. But what are the good practice in terms of HIV programming? You see, there is a good involvement of the UN system. Like I said, many agencies, UNICEF, WHO, UNESCO, and also UNFPA, they are doing a very good job in terms of supporting the HIV/AIDS response in Timor-Leste. This is one of the reasons that I'm right here presenting on behalf of the Timor-Leste government. The NAC has been created, although Timor-Leste was the last one to sign the UNGAS declaration. So they have managed to create the NAC. But the NAC is still under, as I said before, as Timor-Leste consider HIV/AIDS program as a medical issue. So they put the NAC under the Ministry of Health. So which is a problem, because in many countries they put the NAC higher than that. They put it directly under the presidency or under the prime minister. But in Timor-Leste, the NAC is still under the Ministry of Health. They have the 3-1 principle, like my colleague says a few minutes ago, related to his program. They have agreed to the 3-1 principle. So it means that everyone must follow one national program, and there is one coordinating body, and in terms of evaluation, there is only one evaluation body. And the good point also, there is the presence of Global Fund to support HIV/AIDS program, HIV/AIDS activities. Actually, for population less than 1 million person, the Global Fund is supporting the HIV/AIDS program for at least 9 million US. Like I said before, in conclusion, Timor-Leste is still a low prevalence country, but low prevalence means it's time to establish a good prevention program. Like I said before, in Timor-Leste, they still consider the target group the most at-risk group. But we have seen that in the general population, the knowledge about HIV/AIDS is very low. And like I said every time, Timor-Leste, although it is a low prevalence country, they need to focus on their effort, because they can be transformed in a general epidemic country in less than 10 years. Because I gave them the example of neighbor countries that were exactly in the same stage last 10 years ago, and now they have been transformed to a generalized epidemic country. So I said to them every day, Timor-Leste is a low prevalence country, but it is time to establish a good prevention program. Thank you.
Thank you, Dr. Agustin. Now we move to Malaysia. I would like to invite Dr. Karina Rizali, joining us from University of Sarawak side. Dr. Rizali, please.
Okay, thank you, Mr. Chairperson. Can I have my slide up, please?
Okay, now your slide is on the screen.
Okay, thank you. So I'll talk very briefly about the national level HIV/AIDS impact in Malaysia. Next slide, please. I'll cover a few brief topics basically on the epidemic profile of HIV in Malaysia. We'll talk about populations at higher risk because Malaysia shows a concentrated HIV epidemic. What are the current responses and interventions that are already in place, as well as issues and challenges that we are facing here in Malaysia. Next, please. So Malaysia is a country that is made up of over 27 million population currently, and it is actually divided into two geographical areas. The first on the left is the Peninsular Malaysia, and on the right you see is the East Malaysia, or also known as Borneo Malaysia, where it's there with Kalimantan, Indonesia, and bordering with Brunei as well. It's a multiracial and multi-ethnic, multi-religion country. We've got Malays, Chinese, Indians, as well as indigenous population groups. And the main religions in Malaysia are, officially it's a Muslim country, but we also have a significant proportion of Buddhists, Christians, and Hindus. We border with Thailand, Brunei, and Indonesia, Kalimantan. Okay, next. The first reported case of known HIV in Malaysia was in 1986, and it was actually a case imported from injecting drug use. Sorry?
Hello, Malaysia.
Yes?
You were frozen for a while, so we were
Yeah,
not
we can
able
off for a while, but now it's okay. We can continue now.
Okay, can you hear me now?
Yes, we can continue, yes.
Okay.
Yes.
So I'll just repeat this slide quickly. The first reported case of HIV in Malaysia was in 1986, and since then, by the end of 2008, we've had a total of more than 80,000 HIV reported cases. Actually, it's about 84,000 reported HIV since 1986. Malaysia is categorized as a concentrated HIV epidemic country, with more than 5% known among a particular high-risk group, which is the injecting drug use. And among the IDUs, it's estimated that it's about 20% prevalence, and about 5% among men who have sex with men, as well among female sex workers. Next slide, please. The way HIV is documented, notified in the country is through passive and active screening. Through the Control of Infectious Diseases Act of 1988, HIV is a mandatory notifiable disease among government hospitals. So that's how we get most of our reported cases. All donated bloods are screening. Mothers attending antenatal clinics are also given HIV screening. All TB patients, all patients at STD clinics are also screened. Recently, at the start of the year 2009, there was also a new policy introduced where for Muslims only for now, those who are attending premarital courses will also be given mandatory HIV tests. Among injecting drug use, those who are upon entry to the drug rehabilitation centers and into prisons are also tested for HIV. In addition to all of that, the country has also now initiated a voluntary counseling and testing service, started recently and also expanded throughout the country. Next slide, please. This is the graph showing the number of reported cases over the years since 1986. You can see it peaked at about 2002, but in recent years, the numbers of reported cases are declining. And to be honest with you all, we also can't really find a good explanation for this decline. Is it a real decline in the epidemiology of HIV? Or is there some artifact or reporting system or surveillance system? Or if it's actually an impact of one of our intervention measures, which is harm reduction among IDUs. Harm reduction among IDUs was initiated in 2005 as a pilot test and has been expanded recently to nationwide. Some will say it is too soon to see the impact of harm reductions, especially since the coverage isn't that wide yet. So it's one of our key interesting areas to see how far does this trend continue and what can actually explain it. Next. The three graphs shows estimated numbers of HIV. The estimated adult HIV prevalence for Malaysia was thought to be about 0.5% among adults in the year 2007, and the estimated number of people living with HIV was about 80,000 in 2007.